Achalasia. Definition. Achalasia is a motility disorder of the oesophagus characterized by absence of peristalsis and failure of relaxation of lower oesophageal sphincter. This causes obstruction at level of oesophago-gastric junction. The term achalasia means failure to relax and refers to the inability of the lower esophageal to open and let food pass into the stomach. As a result, patients with achalasia have difficulty in swallowing food. Achalasia, also known as esophageal achalasia, cardiospasm, and esophageal aperistalsis, is an esophageal motility disorder involving the smooth muscle layer of the esophagus and the lower esophageal sphincter, les. It is characterized by incomplete les relaxation, increased les tone, and lack of peristalsis of the esophagus, inability of smooth muscle to move food down the esophagus. Incidence. Common in adults, age 25 to 40 YRS. Only 5% in children. Also occurs in elderly in association with malignancy. Structure of esophagus. Oesophagus is a muscular tube, about 25 centimeters long, begins from the pharynx, C6, and ends at the cardiac orifice of stomach, T11. Esophagus consists of 4 layers. These are from inside outwards. Mucosa. Submucosa. Muscularis externa. Serosa. Peristalsis. It is a wave-like contractions of smooth muscles of the oesophagus that propel the food contents onward by alternative contraction and relaxation. Pathophysiology. Achalasia is characterized by increased lower esophageal sphincter pressure, decreased or absent peristalsis in the distal portion of the esophagus, and lack of relaxation in response to swallowing. Myenteric plexus lies in BW longitudinal and circular layers. Acetylcholine and substance, P, are excitatory neurotransmitters causing contractions of the esophagus. Nitric oxide, NO, and vasoactive intestinal peptide, VIP, are inhibitory neurotransmitters and responsible for relaxation of the L.E.S and coordinated esophageal peristalsis. Myenteric plexus provides motor innervation to both muscular layers, secretomotor innervation to the mucosa, and controls esophageal motility. Etiology. Exact cause is not known. Degeneration of myenteric plexus. The loss of inhibitory neurons allows unopposed stimulation by cholinergic neurons, which leads to failure in L.E.S relaxation and aperistalsis of distal oesophagus. Sign and symptoms. Dysphagia. More for solids. Progressive and worsening. May lead to weight loss. Chest pain. Induced by eating. Retrosternal. Infected teeth and gums due to acid reflux, fermented food and poor oral hygiene. Regurgitation of undigested food. Some patients learn to induce it to relieve pain. Heartburn. Sensation of food sticking in lower esophagus. Nocturnal cough. Late features. Inhalation of refluxed contents leading to pneumonia. Weight loss. Investigations. History taking. Physical examination. Chest X-ray. It shows dilated esophagus with air fluid level in distal esophagus. Barium swallow in achalasia. The characteristic features are dilated oesophagus, uncoordinated esophageal contractions, obstruction at the esophago-gastric junction and retail appearance. Endoscopy. It shows narrowing or obstruction of distal part of the esophagus. Also to exclude organic cause of obstruction. Esophageal manometry. Oesophageal manometry test measures the motility and function of the esophagus and esophageal sphincter. A tube is passed through nose into the oesophagus. The pressure of the sphincter and contractions waves are recorded. This procedure has risks of aspiration due to increased salivation. Management. There are 4 treatment options. Pharmacological. Forceful dilatation. Botulinum toxin. Oesophageal myothomy. Pharmacological. Calcium channel blockers like nifedipine and nitrates like isosorbide dinitrate, as calcium ions are responsible for activity of myofibrils and tension generation. C.B act by decreasing calcium entry and reducing the pressure in lower esophageal sphincter. These bring only short-term relief. Side effects are low blood pressure and headache. Forceful dilatation. It is the treatment of choice in adults. Procedure. A balloon catheter is placed into the esophagus and forcefully inflating it within the lower esophageal sphincter. Tear is produced in legs which become relaxed and allow the food to pass into stomach. It has success rate of 60 to 90%. The advantage of dilatation is that it can be repeated if symptoms return. Incidence of perforation varies from 1 to 5%. Botulinum toxin. Botulinum toxin is injected into the lower esophageal sphincter using endoscope and causes local relaxation. It is effective in 90% but effect wears off after several months. 50% of patients will require another TX within a year. Side effect is chest pain after injection. Surgical procedure. Myotomy. This involves a controlled incision into the muscle of leg to cause it to relax. It has a success rate of up to 90%. Heller myotomy. It was first performed by Ernest Heller in 1913. It can be performed either by open procedure, through the chest, thoracotomy, or through the abdomen, laparotomy, or by laparoscopic techniques. Nursing management. Nursing diagnosis. Dysphagia, difficulty in swallowing, related to aperistalsis. Backflow of food related to narrowing of esophageal hiatus. Heartburn related to reflux of food. Pain related to spasm of the esophageal muscle. Anxiety and stress related to disease. Nursing interventions. The nurse works with the patient and family to explore diet and lifestyle modifications that will best control dysphagia, which is prominent in Achalasia. Education begins with careful assessment of the scope of dysphagia, which includes the following: swallowing ability with liquids vs solids, response to foods of different textures and temperature, variability of the dysphagia, response to stress, fatigue and other activities, approaches used by the patient to manage the dysphagia and the degree of success. Give antacid to relieve from heartburn. Give analgesics to relieve from pain. Encourage the patient and provide emotional support. Complications: weight loss, malnutrition, breathlessness, pneumonia, carcinoma.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.